Okay, so is the waiting room now empty? Everybody's moved in?
Yes,
Looks
should be all
like.
set.
Okay, great. Hello, everybody. I am Peter Kraut, rate setting manager at MainCare, and we're here for the first of two technical assistance meetings. I'm going to stay on for this call, but I'm going to go off camera just to listen. And I'll hand it over to Brian Lumbra from MainCare to provide a little bit more context. He is the project manager for this project. So Brian, take it away before you hand it over to Guidehouse.
Sure. Good afternoon, everyone. Welcome, and I'm glad that you all chose to participate in this process. It's nice seeing a lot of people here. So as you saw in the invite, this is your opportunity to get any of the information or assistance that you need in completing these surveys. The surveys are important. Getting this information and data from you is crucial to developing these models. So actively participating, asking any questions that you need to ask in order to assist you in completing this is important. And just know that this session today is not the only session. We do have another one, I believe, on December 5th to ask additional questions. And then, of course, at any time, you are able to email myself, the folks from Guidehouse, at any point during this process to complete these. And do note that these surveys are due to be completed, these cost templates, by December 16th is the deadline. So again, your participation is absolutely crucial. And I'm going to hand this over. We have here three representatives from Guidehouse, I believe. Correct, David?
Yep.
Yeah, we have David Garbarino, Holly McDonald, and I believe, did I see Sean hiding in here somewhere?
Sean is here.
Yeah, right. And Sean Clare. There are a number of us folks that are on from MainCare. So again, we're here to help you, assist you in any way. There's no bad question. Whatever it takes to get you the answers you need to be able to complete these. So with that, I'm going to hand this over to David, and thank you very much again for your participation today.
Thanks, Brian. Welcome all to this first TA session. I want to thank you all for taking the time to, if you're here for 5 minutes, if you're here for the whole hour, that's all good. As Brian said, this is really your opportunity to ask whatever questions you want. As Brian said, my name is David Garbarino. I'm the engagement director for this work on behalf of Guidehouse and working for the state. And what we really want to emphasize is there really is no wrong door for you to ask questions, right? So you can get information from this TA session, from the next one. We're going to be putting out an FAQ document that's already has information on it, but any questions that are brought up today and that we respond to, we will put that out as well. And then I believe you also should have my email, and you can ask me questions directly. So, we really want to emphasize that because we are so appreciative of the time necessary that it will take to fill out this document and how important it is for the overall rate setting process. We want to make this as easy and as low stress for you as we can. So with me today, as Brian said, is Holly McDowell and Sean Clare, who are two other folks on the rate setting team who will be here to ask you questions. We anticipate being able to answer all of your questions right now. On the off chance that for whatever reason you stump us, which is always possible, we'll let you know, and then we will confer and get right back to you following the meeting. I don't expect that to be the case, but want to let you know that that is entirely possible, but I don't anticipate it. So with that, I'm going to ask actually. And today we have no formal presentation. It's really open session. That having been said, I am going to ask Sean to share his screen with the PowerPoint that we send out, which hopefully all of you were able to see it and hear Sean's voiceover explaining how each of the boxes and how each of the tabs should be filled out. So I'm going to ask Sean to put that up, and we'll use that as a reference guide. So if you have any questions, we'll just go to that. And then, if Sean just say a couple of words, just sort of overall about the key tabs, and then let's not take up any more of your time and let you ask questions.
All right, and Brian, would you free up my screen for sharing, please?
One second. I don't know if I'm able. One moment. We do have it. One second. Can you give that a try now, Sean?
All right.
Thank you, Amanda.
You're welcome.
Nope. It still says that host disabled participant screen sharing.
Well, while we get that set up, do we want to start, see if anybody has a question
Yeah.
to start with?
Yeah, that's good way to start.
Let's just jump right in.
I have a question about tab 2 for total charges and units. Should we not include any of the charges that are at zero charge? We have a few small items that we don't charge for.
I'll take that question. I actually would suggest that you do put it in as zero charge. I'd be very interested to see in what services you're providing at zero charge. It sounds like there's a couple of, are they incidentals?
Yeah, there might be urine dips or venipunctures or however, my thought on that is if we include the units with zero charge, it's going to dilute our cost to charge ratio.
Well, if it has zero charge, it shouldn't dilute it. But I mean, you make an interesting point about the units, because that's more akin to a lab, lab volume. As I would include it, but I mean, now that you've sort of made us aware of it, of that type of a thing, we can, because we're gonna parse the information we get from you and sort it out into things that, I mean, our goal is to get your unit, your sort of visit unit, i.e. T1015 or other sort of visit related things. Lab volumes, as I'm sure you probably know, or lab related volumes, we'll say, often, are usually sort of are separated just because those can be very high counts of things, right? So I would put it in, but thank you for letting us know that, and we'll make note of that.
I have a question. Are we just doing main care primary payer or secondary as well?
That's a great question, because because when main care is primary, that's when you're paid the T1015. When main care is secondary to, so you're saying like secondary to Medicare, or secondary, is that largely a dual, like a dual person who's dual?
David, let me
It
ask.
can be either or.
Okay.
It can be
Yeah, go
dual
ahead,
or
Peter.
commercial.
I mean, when this is the case, it's, one date of service, it's still one service, one member, one unit, one charge that becomes bifurcated into two different claims. But so, I'm just trying to think. The template, it's simply asking about units. What's the code? How many units did you bill? And in the case of something where there are two payers, it's still one unit of service with one charge associated
That's
with
right.
it.
Yeah, that's
So
right, Peter.
that's the key thing.
Yeah.
If you were to list it twice, that would really throw things off. because you'd be having 2 units when in fact it was only 1.
That's exactly right. Is because since we're worried capturing main care services, it's still, as Peter said, it's still 1 count of a service. The fact that it has multiple sources, revenue streams, is not what we're capturing on this. Yeah.
Right. Basically, we're looking at the cost side, not the template looks at the cost side,
Not the
not
reimbursement
revenue
side. Yeah.
So it basically, it's just taking the total costs, which we get to from your charges, and then just divides it by the total units. And then then you just have your cost per unit. And that is what the T1015 will be. And yeah, we don't make the distinction between, was it a Medicare or a Cigna, or a main care claim. We're just looking at total cost divided by total visits.
I'm just going to interject really quickly. David, could you right click on Sean's name and just make him co-host? We inadvertently flipped you over to the host. That's what's causing us the issue.
Right click on who?
On Sean, and you can just make him a co-host, and that should allow him to be able to share his screen. Sorry about that, everyone.
No problem. Let me find him on the list.
But did that response make sense to whoever it was who asked? I think it was Alyssa, and really to everybody else, because that's key, that everybody is on the same page and understands that.
Sorry, I didn't have my phone on mute and I got a call, so I missed part of it. But I think my question was stemming is because I thought we were only doing main care claims, not all payers. So we're reporting on all payers.
That's correct.
Perfect. Thank you. You answered both of those. Thank you.
It should be, I think you should be okay now to share, Sean.
Oh, there it is. Okay. So this is helpful just to have up. So if folks have specific questions on tabs, and Sean, as I mentioned, if there's anything if you wanted to say a couple of words, just as a opener, and then we can continue with the questions. And while Sean puts that up there, folks can continue to ask questions.
And I was on mute. So in the interest of moving through this in quick time, I'm gonna move a little bit faster than I did for the video. But just walking through this, start with our introduction. And just the statement of intent. Really, the goal here is to get all visits that could be associated with the T1015, whether it currently is now or not. So we can do a T1015 rate that's based on total costs divided by total visits. Because of the way the services are right now, and to address that past ambiguity, we're getting information from all payers on things that are on the T1015 currently and things that are not. So as the state goes to make decisions on things like the association brought up dental, the state is well positioned to make those decisions on what should stay in the T1015 and what should be billed as a fee for service. So the cost report supplemental itself is an Excel workbook. We've got 5 different tabs, and again, reason for this is that Medicare requires that all the services under G0466 be in the T1015, but leaves the state freedom to choose which other services will and will not be included in the T1015 and how they would like to bill those. So tab 1, actually we'll scooch forward a little bit. Before we get to tab 1, let's talk about the definitions. Total gross charges. This means everything that was charged to patients, or really any payer, without anything being removed, this is not a net charge, it's definitely a gross charge. Total volume is just total units of service for whatever particular code we're looking at. And total cost is cost allocated to each service. If you have a way to allocate those costs. If you don't, perfectly acceptable to leave that blank. But if you have methodology associated with, associating costs with particular service level descriptions, we'd like to see that. Provider information, this is essentially your contact information. We definitely want to be able to reach back out to you if we see anything in the submission that we have questions about. All the regular contact information at the top, please do the date submitted as your last thing so we know the date it was actually submitted. You'll notice on the left, we're asking for your Medicare provider number and your TIN and what your fiscal year dates are for 2018 and 2019. Not all providers have the same fiscal year, and we need to know this when we're trending things forward, applying inflation, anything like that. Anything that involves the time value of money. And your facility NPI numbers are there. There is a spot later where you're asked for NPI +3, but this is just the NPIs for the facilities that are under your particular umbrella. At the bottom of provider information, we're just asking you to certify, print your name. You don't need to put a handwritten signature on this. Typing your name in should be sufficient. Before I go any further, any questions?
I have one. This is Alyssa again. I'll probably have a lot. Where it says the FQHC Medicare provider number, is that the PTAN? And we have a PTAN listed for each facility NPI number.
It should be the number that you use to bill Medicare with.
Medicare A or B?
Most outpatient visits are billed. What are they? Are they billed under B?
A, but we have a PTAN for associated with each NPI number. And we have multiple NPI numbers under our tax ID. So can we put more than one here?
So I just to play that back to you. So for each of your, I presume you have NPIs by location.
Yep.
Okay. And do each of those locations have their own Medicare A and B number?
Correct.
Okay. See, now you've stumped me. Let me sort of step back a bit. The reason we want to collect the provider numbers is so we can link data, right?
Yeah,
so,
to the cost reports.
Yes.
Yeah.
Exactly.
So yeah, we have different PTANs for our cost reports.
But you submit one cost report, for all your entities together.
They have the multiple line items for each provider transaction number for Medicare.
Right, but it's still one 224 document, or is it multiple 224 documents?
Not sure. That's our finance officer that submits them, but I know on the part that I populate, I have to put it based on each PTAN.
This is Sharon. From what I have seen in looking and reviewing cost reports, there's one cost report for each FQHC, and then within the cost report, the information is divided out by a location.
That's
Right.
what I would have thought, and so. So on the 224, I guess you would be recording multiple Medicare numbers because you're saying you have multiple numbers.
Correct. So are you using this field to locate their Medicare cost report?
No, we have all the Medicare cost reports. It's more to align it with to make sure that we're aligning the right entity. In other words, what you submit with the cost report that we already have, and then we'll also be using some other numbers, not the Medicare number, but we'll be using like your NPI +3 to match it up with claims. So we just want to make sure that we're solid in terms of aligning what you submit with your cost report.
So here, David, can we suggest if it's easier for you to provide us an extra, page that has these numbers laid out with the Medicaid NPIs and then with the Medicare cost numbers? I don't think they have to be necessarily included right here. We just want to make sure we have that data so that we can verify. So if there is a question about what should be linked up and who it provides to, that we have the correct information.
That's a great idea. Yeah, that's, if you just want to, because this is an Excel workbook, if you just want to add a tab before you submit it that has just, just your Medicare numbers, that we can take that, we can pull that in.
Sure.
All right.
And Alyssa, you mentioned that you have lots of questions. I want to encourage you to please ask all of them, and don't worry about like, oh, I'm not going to ask this because I'm hogging up all the questions. Having questions and putting them out there is going to help everyone. So please don't hesitate to ask them. Get them all out.
No
Oh,
problem.
yes. We definitely love questions. So looking at the T1015 services tab 2, this is specifically to gather charges, costs, units for things that are required on the T1015 under these particular physician types: physician, physician assistant, nurse practitioner, clinical psychologist, and LCSW. These are the services from the G0466 that are required to be in the T1015. So we want to get a real good idea of what's actually in here. And you can copy paste this in, or however you do your query. But procedure code, procedure description, total gross charges, units, total costs for 18 and 19. And as you go through this, you'll see there's a line number on the left. It'll auto populate. You don't need to do anything with that. And you don't need to worry about any formatting. If you look at it and the formatting looks odd, that's fine. We've got that covered.
Alyssa again. So we have, I know it lists out the types of providers for this. We have optometrists that bill services under G0466. So am I putting the optometrist here as well, or are they going into tab 3?
Ooh, that's an interesting question. Yeah, I mean, this list of those 4 physicians comes straight from the federal statute about which providers, are considered the Medicare must cover. So that's.
If it helps on the cost report, the optometrists are usually grouped in with our MDs. And
Oh, David, Holly, seems like that
Interesting.
would be
So optometrists, which are an OD, I mean, is from our standpoint, from a rate standpoint, since we're not differentiating how different clinician types are paid, we're fine if that is your practice to include them in with physician. Peter, as long as that's okay with you, then we would be fine with that, because the next tab is sort of, I think, all, Sean, just click to the next tab. It's all others, right? I mean, it's really, as you can see, it's dentist, LCPC, chiropractor, or anything else. So
yeah, I agree with Sharon. Yeah, because if Medicare's, in spite of the fact that optometrists weren't included in the statute way back when, if Medicare's practice is, yeah, that's included in the G0146, then that means that state Medicaid programs need to include it in the T1015. And it's not discretionary, because the whole thesis, the whole sort of starting point is, if Medicare includes it in the G0146, that means, yeah, states must include it in the T1015. So that's the principle.
okay, then it should go in that tab.
Thanks for asking that, Alyssa.
So if
Sure. Go ahead.
Optometrists go in tab 2. Does that mean additionally chiropractors, because those can also bill under G0466, 67, and podiatrists also are included on tab 2 now. If we're using Medicare PPS codes as the base.
Peter, this is Sharon. Can I ask a question? I mean, my guess is that when you look at these tabs after completed, you're going to be really looking at tab 2 and comparing that to the costs and visits that are on the Medicare cost report. So presumably you'd want people to include on tab 2 any of those services that are included under the medical and behavioral health pieces of that tab, not the other services that are pulled out separately, but those that are included. Is that correct?
Well, on the behavioral health, one thing that was interesting, that we noted here with the asterisks is, so in the Medicare statute, they mention, LCSW specifically. LCPCs is a sort of main specific thing. So federal statutes certainly wouldn't have mentioned LCPCs. And so that's why LCPCs show up on this tab. Even though, as the footnote indicates, the services that are provided, it's still counseling. It's going to be the same counseling, CPT or HCPCS, regardless of the provider. And so behavioral health would be parsed out between tabs 2 and 3 that way. But back to the other question, Sharon, and I guess Janka it was, so Guidehouse, let's just think about that. So podiatry and chiro are not listed in the federal statute as those G0146. And Janka, the way you phrased the question is you said that those can be billed under the G0146 and Z0147. So it was sort of permissive in that they can, but they're not always. Is that the case?
In a way, yes. So there are instances when those provider types can report an E&M service. So 99202 through 99215. And when they perform that service, it can be reported with your PPS code G0466 or G0467, depending. And then when they're only doing things like debridement or manipulative therapy, then in that case, it is not billed out with a G code.
Okay, I think the cleanest way to do it is to, so while on optometrists, it seems pretty cut and dry that those should be on tab 2 because they're really comparable to, you always list them on your cost report as if they're physicians. And because it's always billed under the G0146. In that case, it seems pretty cut and dry to have that on tab 2. But for chiro and podiatry, I think it would be cleanest to have that on tab 3. Now, that's not to say that it's going to end up being that those services aren't included in the T1015. I mean, we know that I think most FQHCs do bill those under the T1015 currently, and that can continue to be the case. We just, this is where we get into the distinction between tab 3 and tab 5, where CMS has been clear with us that if the state is going to say, and I'll just pick chiro as an example, that chiro's in the T1015, that means any FQHC tax ID that does chiro needs to bill it under the T1015 and can't bill it outside. So that's the reason for the distinctions between tabs 2, 3, and 5, so that, we have that distinction about what, because one FQHC might be currently billing all of their chiro under the T1015 and another one isn't. Another one is doing it outside the T1015 under a different, under a different service location, a different MPI +3 that's under the same TIN. And so CMS has told us that's not okay. And so we just want to get that info about who's billing what where, so that we can just come up with a uniform, and I'm just going to use this as an example. Yes, Cairo should always be in the T1015. And so it's okay that you're putting that on tab 3 instead of tab 2. Did that clarify things or make things muddier?
I mean,
Clarified
I
for
think
me.
it helped for me.
And Peter, if it's worth mentioning, we're trying to, the supplemental cost report was designed, and as Peter alluded to, reflect what's in sort of federal statute. But in terms of how we determine the rate and what's in and what's out, it will be based on sort of what federal statute requires the state to do and the information we collect. So, we will take this information and parse it appropriately. So don't be concerned that if it's in one tab or another, it'll be treated differently. Either it's the structure of the cost report is as much about capturing information in a certain way, but it does not preclude it being used similarly. So don't fret. In other words, if it's in the one tab and say, oh goodness gracious, I should have put it in the other tab. Don't worry about it. It's there. What's most important is you put everything in. Don't put it twice. Put it in once. But we will capture it. We'll sort it. We'll parse it as appropriate, and then we'll come up with we'll make recommendations to the state, and they'll decide what is and what isn't in the 1015 and what is not. So I don't want this to sort of create any sort of concerns. It was really a way to format the supplemental cost report in a way that sort of was consistent with federal statute. So hopefully that allays fears, but don't worry about where if you put it one place and someone puts it in another. It's not going to impact you. It's really, we just want to make sure you put it in.
And I'm just looking at Charity's comment in the chat. And Charity, do you feel like the discussion has answered your question, or would you like to have more discussion about sort of the specifics of what you asked? Charity Rudge.
The FQHC guidelines are chiropractic and podiatrists are recognized providers for FQHC.
Absolutely. Absolutely.
So they should be reported, in my opinion, under all medical services, because they are considered an approved provider for FQHC.
Absolutely.
Sean, could you go back one slide?
Absolutely.
And thanks, Sean. And so just to address that, Charity, so we are capturing them that way. Tabs 2 and 3 are both services that are that you are currently billing within the T1015. The only distinction between tabs 2 and 3 is that tab 2 are those 4 provider types that are listed in the federal statute. That Medicare is just super clear that that states are always going to be building those into the T1015. Tab 3 is the ones that, okay, and I see this is what's raising your question, where it's CMS is saying it's optional whether the state would include that in the T1015. And so everything that you put there, by definition, this tab is asking for the things that you are currently. And so I think I hear that your concern is that we're saying those are optional, and your concern is saying, no, it's not optional. Am I understanding your question and concern correctly?
Yes, basically, because the FQHC guidelines are, in the list of approved providers is chiropractic and podiatrists. They are approved clinicians for
Okay,
FQHC services.
okay. I get the concern. And I guess what I could say is, oh, first, that makes sense what you're saying. Second, our referring to this tab and as optional. Okay, and so we will dig into that. And so thank you for raising it, that basically you're saying it's not an accurate characterization, at least with regard to the providers that you're mentioned, that this would be something that CMS would consider optional. The other thing that I would say to allay concerns is, you know, as David Garbarino from Guidehouse had indicated, you know, this tab isn't about, it's ultimately not going to be used to move things out of the T1015. It's more about identifying those services where some FQHCs might be putting a service on tab 5, where other FQHCs are doing it. So tab 5 is, they're not doing it as a T1015, whereas most are doing it under the T1015. And so that identifies for us, hey, when we do our SPA, to make clear that, you know, whatever services we're talking about are in the T1015, any FQHCs that had been billing it outside of the T1015 must now bill it under the T1015, but also to make sure that for those FQHCs, the costs of those services get built into the rate. Does that make sense to folks the way I said that?
Yes.
Okay, but again, thank you for raising that point about those particular providers being identified as you know, always in, and we will dig into that.
And I just wanted to emphasize for this whole process for everybody that this data is meant to help inform the process. It's not meant to penalize anybody or cut out any services. You know, we're not saying that, you know, suddenly this isn't going to be a covered service. This is really to help clarify how the rate is established and what, like Peter was saying, is included in the SPA, so that going forward, everybody has a very clear understanding of what's in that rate.
And if it helps, let me just build on what Holly just said, is because I know you all are familiar with the 224, and that captures all your costs. But the way I've been thinking about this is sort of the distinction between sort of a vertical and a horizontal distinction, right? I mean, the 224 captures all your costs, but it's sort of at a, we'll call it at a rev code, you know, at a rev center level, where we're trying to get it at the procedure line level. We're trying to get the service line to get some more information. Of course, we have claims that you submit, but this just helps us put the whole picture together. And so this, in addition to the 224, will give us a more three-dimensional view of the services you provide and what's the best way to make sure we ensure we capture your costs and build it into the rate that you're reimbursed. So it's hence why it's a supplemental, you know, but you know, in addition to the 224.
And to reply to Jessica's question, yes, except that we got to bump up the number of each, because tab 1 is just the provider basic info. So tab 2 are the providers. CMS specifically say the state has to include them. Tab 3 is providers CMS says are optional for states to cover, and Maine has elected to cover them, with the caveat about what Charity had just brought up. And then the next tab, which is tab 4, tab 4 are the services that show up in section 31, chapter 3, as not being, you know, having a separate rate that's outside the T1015. It's the services that we call the fee for service, you know, like vaccine administration and, you know, smoking cessation classes and diabetes education classes and contraception. So, and that's, yeah, what Sean has up on the screen right now. And so those are also optional. But Yeah, we're asking for it separately because theoretically they could be moved into the T1015. It just sort of we'll see what the data show and what the data suggest would be the best approach.
Peter, this is Sharon. Can I ask a question? And this is based sort of on me getting individual questions from folks, and so wanting to make sure those questions get answered. By sort of splitting up services between the tabs 2 and 3, using this list of mandatory versus non-mandatory provider types, is that if you're going to try to match things to the cost report, is that not going to make that more difficult for you to do, where there are going to be, so your tab 2 isn't going to match exactly there, because there could be services under tab 3 that are also included in the Medicare cost report.
Oh, absolutely. Yeah. Tab 2 would only add up to a subset of what's on the Medicare cost report, right? Right, David and Holly?
Yes. Yes.
Okay. So I think that just will ease some people's minds to know that you're not expecting that to necessarily equal, because some services on tab 3 would also were also included in their cost
Right.
report.
And I think it's worth saying that when we say we're trying to match up, we're in no way auditing, your CMS 224. What we want to make sure is that when we get this data back, that it's as complete as possible. It's basically as a second set of eyes for you, right? In other words, to say, oh, make sure. I mean, that we would expect all this data together to more or less, add up to your 224. The idea is because we want to, make sure that and help you provide us with sort of the complete universe of information. This is not a sort of review or an audit or a check on you. It's really just for us to calibrate what we get to make sure that, hey, did you make sure you got all your dollars in, kind of a thing. That's really, when we say match up, that's really what we're trying to do, is ensure completeness, because we understand and there's a lot going on. People are busy, and it's entirely possible something could get missed. And we just want to be that second set of eyes to help you make sure, you put everything in. So don't think we're not checking on you.
Yeah, I was looking at one of the cost reports because I was thinking about whether or not it would have made more sense to do this by the cost centers that are listed on the cost report, as opposed to, the provider type. But as long as there's an understanding, right, that it's not ever going to match,
Yeah,
I guess that's okay. And that I have some other questions that
please
that I'm
Go for
getting,
it,
if you don't mind if I ask a few.
go for it.
So the total cost column that's on here, is that cost that you're pulling? It's not a gross charge times volume or anything like that. It's a total. If the health center can identify the total cost by service, then they should put that in there. If they cannot identify that because they don't have sort of like overheads right allocated, then they would not include that. Is that correct?
That's
Or they would
correct.
Just maybe.
It's absolutely correct.
Would they put somewhere like a sum of their total cost, just so there's a total somewhere?
No, that's absolutely correct. In other words, we put that column in. I mean, for those FQHCs that have cost accounting, and so therefore can allocate their costs to an individual service code multiplied by the volume, then we welcome you to put it in. If you can't, as Sean said, don't worry about it. And so that's really why it's there. I mean, that's the one column I would say that you can fill out if you can. Otherwise, don't worry about it. What we're the key things, of course, are charges and volumes.
I'm curious why, because this has come up from several different providers, why charges seems so crucial of an element to capture. Health centers, of course, have a usual and customary fee schedule, which I'm guessing is what you want in here, but that doesn't necessarily equal what the actual cost of that individual service is. especially when you think about the way FQHCs provide services, right? And that it's a bundled payment, usually with multiple pieces that are, multiple services that are included at one time. So I know there's been many questions about that, and particularly around sort of thinking about, its impacts when you look at, free services and that sort of thing, that or reduced rate services that people are doing under their sliding fee. So I don't know if you could just explain more about why that's needed, I think.
Sure. So what we mean by charges is really your top line charges that come right from your charge master, right? In other words, nothing reduced. It comes, right out of your charge master, and that would go in regardless of the revenue side, whether it ends up being fully discounted, contractualized by a payer, however the revenue stream is handled. That's separate. We want charges, and it's largely because it is a way for us to compute cost. And as we compute an overall cost to charge ratio for you, and we can ascribe cost at the service line level. And that's why, in an ideal world, and this doesn't necessarily just apply to FQHCs, but all providers would have the ability to have cost accounting, but they don't, and that's the norm. So if you do, that's great. We'd like to see that information, but that's why we want sort of unredacted, unadjusted charges, gross charges, as I like to refer to it as.
But doesn't that assume that what you charge for a service is actually covering the delivery of that service? I don't know that that's always the case for every service.
I don't want to. We're not going to interpret or sort of presume anything. I mean, I would think just sort of, just speaking extemporaneously, that, when you set a charge for a code, it does cover the cost for it. But I don't want to sort of speak about your charge strategy, So
I guess I think Hilton was just thinking that the total cost information would be the information that was used in developing a rate, and not anything based on the gross charge by service.
And Sharon, we wouldn't use the gross charges to develop the rate. Let me just give an example of how info that's based on this might also ultimately get used. So first, just to give, just like a high level example of how applying a cost to charge ratio then works at the service code level. So, we take the total charges that you give us, we add them all up. So that column that says total gross charges, we add it up across all the different tabs, and let's say it's $2 million. And then we know from your cost report that the costs associated with all the services that you provided was $1 million. So you've got a cost to charge ratio of 2 to 1 or 1 to 2. And so when you then tell us at a service line level that, we had, $100,000 in charges for this service, for this code, we then use the cost to charge ratio just as the best proxy that we have to say, well, they've got a 1 to 2 cost to charge ratio. That means the costs of this service were $50,000 because the charge was 100. Now, yeah, you're absolutely right that, the ratio at every single service level, it's going to vary, but, FQHCs, if they don't have, cost allocation methods to capture that more granularly, it's sort of the best way to impute a cost for a given service. And so how that might then get used in developing the rate is, well, let's say that on tab 5, we see that there's an FQHC that, had $100,000 in Cairo charges, which is $50,000 in Cairo costs. And we're going to decide, Cairo should always be in the T1015. We then have a way to move to say that Cairo at this particular FQHC cost $50,000. Let's move those $50,000 in costs and the associated, 1,000 visits into the calculation of the T1015. And, that's sort of because we don't have the ability, I mean, an alternative to using that approach would be sort of like a mini change in scope for everything that gets moved by that, where you tell us the actual salaries of the Cairo and the actual, floor space. And that's just bigger than the rebasing project. And so
your intent is to be able to have this information to use for things like that beyond the rebasing. I don't know, like
no, not beyond the rebasing. It's only for the rebasing.
Because I'm seeing a lot of comments from people around sort of their fee schedule, like our fee schedule hasn't been updated in several years, as in their usual and customary. And then the fact that very often in the usual and customary charge, they're not covering in that cost the sort of that ancillary staff that really helps an FQHC operate, like community care teams, the community health workers and care managers and IT. And that has not necessarily been wrapped up into their usual and customary charge. So it's not very reflective of actual costs, I guess is what.
Yes,
what
but I'm
I'm seeing
reading
in the comments.
Lori's example, and so what's going to happen is you're going to have a lower charge to cost ratio, because all the CCT costs, the IT, the quality staff, it's not included in the charge, but it is included in your costs. And so the ratio, I mean, the charges are what they are. I mean, if your costs actually are exceeding your charges, David, that would be a pretty rare situation. But in that event, it would mean that because your total costs exceed your total charges, it means we would gross every chart when we, if you have $100 in costs, in charges, we would then know, oh, we need to gross that up. That means $110 in costs. So
can you explain to me again the purpose of having a cost to charge ratio in doing the rebasing? I guess I'm not seeing its purpose in the rebasing when you have the total cost information already.
It's having the charge to cost ratio enables us to impute cost at the service level and then be able to, in the event that there are decisions made to, and I'll use the Cairo example, that Cairo is always going to be in the T1015. If we didn't use the cost to charge ratio, we wouldn't have a way of knowing what that FQHC's Cairo costs were. And so that's the purpose.
I think that you could get that information, but it just, when you say it like that, the way I'm interpreting it, and I'm not trying to be argumentative and I'll stop talking after this, is it sounds like this information will potentially be used for other things than just the rebasing. That it would be used to look at a change in scope potentially.
No, we wouldn't use it for a change in scope. I mean, we definitely wouldn't be using it for a change in scope. When we do a change in scope, we do that process with the FQHCs, where, give us the salary, give us, the overhead. So, and that will continue. This is really for the rebasing, so that, I mean, I understand what you're saying, Sharon, about some of it's sort of semantic, the difference that you and I are how we're talking about it. So when I say it's only being used for the rebasing, and you're saying it sounds like it's also being used for something change in scope-ish, it's because the way I'm thinking about it is as part of I mean, if you go back to the statement of intent, there were those two bullets. Yes, we're rebasing, but in order to do the rebasing, we have to address the ambiguity we've had up till this point in time about what's in and what's out.
So is this really about, because I know this came up when I was there before, but the fact that some health centers do certain services under the T15 and some are enrolled under that section of policy and providing services there. And so the thought is that the state may try to say, if you're an FQHC and you provide these services, it has to be done under section 31 and you can no longer enroll in a different section. I mean,
Yes, that's exactly that's exactly the point, because CMS has told us that that's not okay. And that, you know.
And so you want to be able to take into consideration the cost of that service.
Exactly. And we don't, we don't even know. I mean, all we're trying to do is get the data. There really isn't any, agenda about, ooh, this should be in, oh, this should be out. We just, we're just trying to get the data to see who's doing what, because CMS has made clear to us, hey, you can't have some do it one way and one do the other. Whatever the decision is, has to be applied consistently across all FQHCs. And so the data will allow us to see, I'm just making stuff up. Oh, of the 15 FQHCs that already do Cairo, that are doing Cairo, 13 of the 15 have it in their T1015, but 2 of them enrolled separately to bill it outside, and CMS has told us that's okay, not okay. And so, now we know, now we have the data in front of us. And so, to be compliant with CMS guidelines, we've got to, those 2 that don't need to have it moved in. And so now we'll have their costs. No, Sharon, this was, thank you for bringing up this issue, because we know that it's been really confusing. So this is very good use of time.
And I was just going to add, Sharon, if it helps, it's easy to think about, while yes, the primary objective here is to rebase and develop a new rate for T1015, but what the state has asked Guidehouse to do is do a comprehensive analysis. Right. And so, and we have, for your edification, we've done this in a number of states, and the process that we're going through here is to collect the same kind of information we collect elsewhere. So we're not sort of singling folks out, or, as Peter said, there's no other agenda other than what he already stated a moment ago. But this is sort of per usual for doing a comprehensive analysis of FQHC rates to develop 1015 payment.
And so we are out of time. We have another session this coming Monday, but also, I mean, everybody should just feel free, reply all to the invitation with further questions, and we could just keep this conversation going through email. Because with the December 16th deadline, we know folks need to get started. And so if folks don't want to wait until, next Monday for further questions, feel free to email Guidehouse directly, feel free to CC this whole group, feel free to go through MPCA. Like David said, no wrong door, but we want to make sure that there's no confusion about how to fill out the template or the purposes of the template. Because if there's confusion around the purpose of the template, it influences how you fill it out, and there's anxiety, and we just really want to be clear and all be on the same page. Anybody have any parting words before we jump off? And sorry we ran over.
Well, thank you everyone for taking the time. And just to second what Peter said, you can reach out to any of the means that that Peter has listed. As I said, we will be updating the FQHC FAQ document. You should see that in a day or so. And so, if you weren't madly scrambling and taking down notes, we will let you know what you asked and what we said. So, just keep plugging away at it. And we really look forward to getting this information back. And thank you.
Thank you all.
Bye-bye.
Have a great day.